Assalamu alaikum wa rahmatullahi wa barakatuh. It's my pleasure to welcome you on this webinar, and I hope you will find it fruitful and beneficial. Can you put the slides, please? Okay, good. So today our topic is symesia, more attention to axial SPA patients. And I need to know how this works. Okay, good. And just to remind everybody, this meeting is organized and sponsored by Newbridge Pharmaceuticals, and the view expressed in these slides are those of the individual faculty members and don't necessarily reflect the view of the company. Our objectives for today is to apply the proper recommendation for management of axial SPA patients, to adopt the holistic approach to optimize axial SPA patients' care, and to highlight the role of symesia in management of axial SPA patients. Symesia is in the market since 2008. It is an EMA and FDA approved for rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and non-radiological axial SPA and plaque psoriasis. We have more than 20 years clinical experience, more than 10 years post-marketing experience, and more than 80 clinical trials. There is more than 420,000 patients per year worldwide. So I'm pleased to introduce our speaker for today is Dr. Atul Deodar. He's a professor of medicine and medical director of rheumatology clinic at the Division of Arthritis and Rheumatic Disease in Oregon, Portland. He's a board certified in internal medicine and rheumatology, and he's a fellow of the American College of Rheumatology and also American College of Physicians. He is the author of 3 books, over 250 peer-reviewed articles, several books, chapters, and editorials. Dr. Deodar has been a principal or co-investigator on more than 100 clinical trials, mostly focused on therapies for ankylosing spondylitis, psoriatic arthritis, and rheumatoid arthritis. We have a recorded lecture, so they will put it for you now. So.
To axial SPA patients. Let's see. So spondyloarthritis belongs to a family of heterogeneous inflammatory diseases, and they have overlapping clinical features. What is shown in this figure is the journey a psoriatic arthritis patient, which is psoriatic arthritis is peripheral spondyloarthritis, takes, and at the bottom of the lower part of the figure shows the journey taken by an axial spondyloarthritis patient. As you can see on the top, patients with psoriatic arthritis mostly start with psoriasis first, and over the years they develop preclinical psoriatic arthritis, subclinical psoriatic arthritis, and then psoriatic arthritis. And at the bottom you see patients starting with non-radiographic axial SPA. Even before that, they generally have inflammatory back pain, and then some of them go to radiographic axial SPA. The important point to remember is not every patient with psoriasis will progress to psoriatic arthritis. As you know, 30% of patients with psoriasis will get psoriatic arthritis. When it comes to non-radiographic axial SPA, only 50% of patients with non-radiographic will develop radiographic. And if you start from even before that, inflammatory back pain patients will have only 15% of them will have axial SPA. These are the overlapping clinical features that I was talking about, and I'm going to take a little bit time here on this slide because later on in my presentation I'm going to talk about this, that when we are treating a patient with spondyloarthritis, we need to choose a drug that not only treats the musculoskeletal problems of spondyloarthritis, but also the other clinical features as shown here: uveitis, psoriasis, IBD, inflammatory bowel disease, sacroiliitis, peripheral arthritis, enthesitis, dactylitis, etc. And what this slide also shows is uveitis is more common in axial SPA than PSA. Psoriasis, of course, is practically every patient with psoriatic arthritis will have psoriasis, not 100%. Inflammatory bowel disease is very similar in both these conditions. Sacroiliitis or axial disease, more common in axial SPA compared to PSA. So this slide shows you the evidence of sacroiliitis by X-ray. The problem with X-rays is that the two experts may not exactly agree upon the grade of sacroiliitis. What is shown on the left-hand side is non-radiographic axial SPA, the first X-ray. Non-radiographic, this name is still confusing to some people. Non-radiographic does not necessarily mean the X-ray is completely normal. Patients with unilateral grade 2 sacroiliitis is still non-radiographic, and grade 2 sacroiliitis is in fact sclerosis and even a little bit of erosions. But if it is unilateral and the other side is grade 1 or grade 0, that becomes still non-radiographic. And then over the years, as I said, over the lifetime, only 50% of the people with non-radiographic could become radiographic axial SPA, also called ankylosing spondylitis, in which there is at least grade 2 bilateral or grade 3 or 4 unilateral or higher. And that's when they fulfill the modified New York criteria. So here I'm going to show you the two treatment guidelines, the ASAS-EULAR treatment guidelines of 2016 and the ACR Spartan SAA treatment guidelines. This is SAA, Spondylitis Association of America, and Spartan is the Spondyloarthritis Research and Treatment Network and American College of Rheumatology. The goals of the treatment are very similar. They are to alleviate the symptoms, to treat the patient's signs and symptoms, improve their functioning, maintain their ability to work, and decrease the complications, and also reduce, if possible, skeletal damage as much as possible. So again, patients should be individualized based on those other features. Extra articular manifestations, extraordinarily important. This slide is a summary of the 2019 ACR SAA Spartan treatment recommendations. These are color-coded. You probably have seen this before. The dark green is strongly recommended and dark red is strongly recommended against. Light green is conditionally recommended and pink is conditionally recommended against. So first line therapy is non-steroidal anti-inflammatory drugs and physical therapy. Second line therapy is anti-TNF. And then the third line therapy is, in primary failure of TNF, we should go to secukinumab, ixekizumab, the IL-17 inhibitor. If there is secondary failure, then we should probably go to a alternative anti-TNF. And then there is also tofacitinib as the fourth line therapy. Now, the EULAR ASAS treatment guidelines specifically say that treatment has to be individualized. And what do they mean by individualized? Again, drugs should be efficacious that you use should not only be efficacious for musculoskeletal, but also for extra articular manifestation, and they need to be taken into account. Not every drug works on the inflammatory bowel disease or the uveitis, which is that we use in patients with axial SPA. For example, IL-17 inhibitor therapy should be avoided in patients with active inflammatory bowel disease. And this is the theme that I'm going to come again later in my presentation. So that brings me to Cimzia. Cimzia is a monovalent FC-free pegylated anti-TNF antibody as shown here. It is only the Fab portion, and this pegylated anti-TNF is basically to prolong the half-life of this particular antibody, and it reduces mast cell degranulation also. So there are two major studies which have been done specifically in non-radiographic axial SPA. The first one, actually, rapid axSpA study, included both the entire axial spondyloarthritis population, which means there were patients with ankylosing spondylitis and non-radiographic axial SPA. But I will show you later another study, phase 3 study. So there are two phase 3 studies. First one is rapid expa. Second phase 3 study in non-radiographic axial SPA is called C-expand. But this is the primary endpoint, and this in fact is extended up to 192 weeks. It shows ASAS 20 response, ASAS 40 response, and ASAS partial remission in both ankylosing spondylitis shown in blue and non-radiographic axial SPA in orange color here. And what it shows is patients treated with Cimzia have equally good response when it comes to ASAS 20, ASAS 40, ASAS PR, whether they have ankylosing spondylitis or whether they have non-radiographic axial SPA. And this is kind of extended, and this is non-responder imputation. This is the tightest way you can look at this. Not all anti-TNFs are approved for axial SPA indication. In the EMA, all TNF except infliximab have indication for both radiographic and non-radiographic. In the US, Cimzia is the only treatment, well, only anti-TNF, I should say, approved for non-radiographic axial SPA, and that comes from this study, C-expand. This is the second phase 3 study in non-radiographic axial SPA for Cimzia. On the left-hand side, you're seeing the ASDAS major improvement, primary outcome 47% versus 7%. On the right, you see ASAS 40 response, very robust responses. Based on this C-expand study, Cimzia got approval in the United States for non-radiographic axial SPA. That brings me to the other non-musculoskeletal complications in axial SPA. Uveitis, this is the commonest extra-articular manifestation in axial SPA. The classic uveitis in axial SPA is episodic. It is recurrent. It is unilateral. It is quite severe pain, and there is a flare, and then there is a quiescent period in between flares, and it flares again. And about in the lifetime of a patient with axial SPA, they get 40% of the patients get this acute anterior uveitis recurrent. And there is this very interesting study called C-VIEW. This was done on Cimzia. And for this, we took patients who were HLA-B27 positive, number one. Number two, they had to have active axial SPA. And number three, they had to have at least one or two acute anterior uveitis flare in the year before they got into the study. So these patients had recurrent flares in their previous year, one or two flares at least. And then they were open label treated with Cimzia, and we compared number of flares that happened in the treatment year compared to their same flares in the year before. And what was found, as shown here, is the primary analysis revealed 82% reduction in the acute anterior uveitis flare event rate during the certolizumab treatment period compared to the same patient pre-treatment. And what is shown in this another bar graph on the right-hand side bottom is the acute anterior uveitis event rate decreased from 97.5 to 17.7 during 96 weeks of this treatment. Gut and joint are connected. Patients with IBD have 10% patients with inflammatory bowel disease develop spondyloarthritis, whereas 5 to 10% of patients with spondyloarthritis develop inflammatory bowel disease. Prevalence of spondyloarthritis is less than 1% in the population. However, if somebody has inflammatory bowel disease, much higher risk that these people will have spondyloarthritis. And this slide shows, and I won't go into too much detail, but certolizumab pegol is shown on the left-hand side top, infliximab and adalimumab shown on the right-hand side. These are monoclonal antibodies, and the monoclonal antibodies have shown improvement. Etanercept, which is a soluble receptor, has not shown improvement. And IL-17 blocking drugs like secukinumab, in fact, should not be used in patients with active Crohn's disease. This is their trial, which showed that it was not superior to placebo. That brings me to enthesitis in spondyloarthritis. Enthesitis is a hallmark of all axial spondyloarthritis and even peripheral spondyloarthritis patients. In the knee joint or in the big sort of joints, there is a synovial enthesial complex as shown in the top part of the figure. In the bottom part of the figure, it shows entheses which are distant from the joint, such as along the heel. This is not enthesial. This could also be enthesio synovial complex, but some of these entheses are distant from the joints. And getting back to the rapid axial SPA study here, I'm showing you 2 dosages of certolizumab pegol, 200 milligram every 2 weeks or 400 milligram every 4 weeks. And over 192 weeks, overall axial SPA population, which had complete resolution of enthesitis as measured by Macy's. So Cimzia works very well on enthesitis. This is a picture of dactylitis, and Cimzia treated patient in the rapid PSA study. Now this is rapid PSA study. There was complete resolution of dactylitis shown here, and here you're seeing the 2 bar graphs of 2 dosages of certolizumab pegol, 200 milligram every 2 weeks or 400 milligram every 4 weeks. Highly statistically significantly better than placebo. Psoriasis is another major extra-articular manifestation in patients with peripheral and axial spondyloarthritis. 6% of patients with ankylosing spondylitis may have psoriasis, and this is the SYMPASI study. Cimzia takes control over the psoriasis quite well, is shown here in PASI of less than 3. On the right hand side, you see PASI of less than 2 and PASI of less than 5. And this is a very effective drug for reducing the patient's skin psoriasis. So this is the absolute PASI scores at week 144. Getting back to the safety of Cimzia, it's a anti-TNF drug. We are very well conversant with the side effect of anti-TNF drugs. And what this slide shows is the exposure-adjusted 204-week population treatment emergent adverse events, or TEAEs. Severe treatment emergent effects are shown here. This is nothing new. There were no deaths reported. This is the rapid AxSpA study that I'm showing you. The way Cimzia is used is for rheumatoid arthritis and for psoriatic arthritis, and also for axial SPA. The loading dose is 400 milligram at weeks 0, 2, and week 4. So it's a 200 milligram injection. So you take 2 injections at baseline at week 2, week 4, and then the maintenance dosage is either 200 milligram every 2 weeks or 400 milligram every 4 weeks. And that is the dose that you use after the loading dosages. So in summary, Cimzia provides a rapid and sustainable improvement in the signs and symptoms of axial SPA. The evidence of Cimzia supports the effectiveness across all extra musculoskeletal manifestations. That is uveitis, that is IBD, that is psoriasis, that is enthesitis, that is also dactylitis, and peripheral manifestations like peripheral arthritis of axial SPA. And Cimzia is the first and currently the only anti-TNF approved for non-radiographic axial SPA by the FDA. Thank you very much.
Okay, the next slide, if you have it. Okay. Okay, so in summary and to close this minibar, we have, can you go please? Okay, we have looked over the recommendation for the axial SPA diagnosis. We reviewed the recent guidelines update for management of axial SPA, and we emphasized the importance of extramusculoskeletal manifestation and peripheral manifestation in axial SPA management, and we have highlighted the evidence of Cimzia that support the effectiveness across all EMS and peripheral manifestation of axial SPA. Thank you very much for you waiting until late time, and thanks to Newbridge for their support. Thank you.